Hi, welcome. Thank you for inviting me again. It's really, again, an honor to be here. It's such a beautiful institution. I look forward to touring it a little bit later. How bright and airy this is, and the beautiful artwork. It's really a phenomenal environment for all these sick children, and I really think you should be commended for creating such a great center. What we're going to talk is a little bit different. We're going to talk about therapy for children with progressive low-grade gliomas. And we're going to move fairly rapidly into the molecular targeted approach of this. But I wanted to give a little bit of background of what you expect with more standard chemotherapies and how, at least in the United States, we're trying to move forward. It's also very interesting when you took a look at the data presented earlier about the incidence, how many low-grade gliomas you see here. And once a great opportunity to make a real contribution to the field of trying to use this information to develop new protocols. The first decision for all of these low-grade gliomas is, does it need to be treated? And this is probably one of the more difficult things sometimes to try to discuss with a family, especially when you have neurofibromatosis. Do you need to really treat the child? The second question, as always to me, can it be surgically removed? If it can be surgically removed, which is location, that is what needs to be done. Then you don't need to worry about all of the other therapies. Should radiation therapy be used? This is something we're going farther and farther away for low-grade tumors. Sometimes we make it very difficult on ourselves when we come back to talk to families about radiation because they're so worried about it and the side effects. And then chemotherapy, risks and benefits versus, and try to stay away as much as we can for any kind of really toxic chemotherapy, and then the issues of molecular targeted therapy. The goals of therapy, and this is critical, the goals of therapy can't be survival alone. It has to be, in many of these children, they are going to survive. And the goals of therapy also have to talk about what are the acute, chronic issues related to treatment, including surgery, and what is going to be your functional outcome. And the morbidity of treatment, how well do we know what it is? We know chemotherapy. We know the long-term side effects. We honestly do not know the long-term side effects of many of our new molecular therapies. This is a paper that came out fairly recently in Neurooncology to show that, we've had many trials over the years for children with low-grade gliomas without neurofibromatosis. There's over 1,500 children that have been treated, and there isn't anything that new. Most of them have been with carbovincristin. Some have been randomized. Interestingly, when you look at the trials, although you think of low-grade tumors and chemotherapy only with those of the chiasm and hypothalamus, a significant proportion actually did have brainstem and other involvements. And when you take a look at it, the event-free survival at 5 years, it just sits somewhere in that 40 to 50% range, maybe a little bit lower. You get a lot of early disease control, but you do lose control over time with the chemotherapy, whether it's carbovincristin or vinblastine or more complex regimens. So well over 1,400 children with newly diagnosed disease have been treated on prospective studies, carboplatin and vincristine in over 1,000. Trial designs have varied. It's very difficult to compare across trials because of different eligibility and also different thresholds of when people will start therapy and will not. Progression-free survival early is good. At 5 years, it sits in this range. But overall survival, because we tend to go from one therapy to another therapy to another therapy, is nearly 100%. And we do a terrible job so far of determining the functional outcomes. And many of the trials have taken 7 to 10 years to go. This is one child that we cared for many years ago with a low-grade glioma. After surgery, had progressed, treated with carboplatin and vincristine, and went down to that, maintained that response, and this is one of the lucky ones. Never has had to be retreated, now about 15 years later. Most will activate. What are our tools to decide who needs to be treated and who doesn't need to be treated? We know of all the difficulties of evaluating very small children, especially as regards vision. A tool that we have used widely at Children's has been OCT. OCT usually needs a big apparatus. There is now for ocular computed tomography to look at the nerve layer, a handheld mechanism. And this is a very good way to get some idea of really the retinal thinning of the retinal layer and whether you're going to get into trouble or not. And work by Dr. Avery at our group and now Dr. Stashev has shown that over time, children who get into visual problems get into it after there's been some thinning, and in some cases you can really predict who's going to get into trouble early. We have never only treated a child on the basis of OCT, but I think that over time, for the new trials that are going to be done, this will be one of the techniques that is going to be used, at least in an exploratory method, because it's so hard to test acuity. The regimen that we've used for many, many years has been the carboplatin vincristine regimen. You know about it. We haven't changed it. It's 10 weeks of induction with vincristine on a weekly basis, carboplatin weekly, 8 out of the 10 weeks, and then maintenance therapy. This is the regimen we know a lot about. We understand that it randomized, there isn't a great deal of difference between it and TPCV, which is the more aggressive regimen. But the question is, why haven't people then grabbed TPCV as the real alternative? Because there's toxicity to it, and the long-term toxicities are something that people worry about. And then for patients with neurofibromatosis, which is the other subgroup of major patients with low-grade gliomas that go on therapies, here we still have lots of information on these patients. People have been very hesitant, except for the French group, to use alkylators because of the risk of secondary tumors. And children have been followed for many, many years. And the survival rate at 5 years, progression-free, is really even better in the subgroup, sitting around the 60 to 70% change rate. But once again, very little good data on functional outcome. So over 550 children with newly diagnosed disease treated on those prospective trials. Overall survival remains approximately 100%. Progression-free survival in the 60 to 70% range, and very poor functional outcome assessments. And this is one of the more recent trials, the COG trial. You can see comparing NF to non-NF patients treated with carbovincristine, how the NF patients hold their response, and about 2/3 after initial treatment do not need to go on to anything else. Now, there have been issues of what do you do when a patient relapses from carbovincristine? Do you retreat? Do you use vinblastine? Vinblastine has been shown by Dr. Buffet in a smaller number of patients, less than 100, to be an effective frontline regimen. And one of the things that we stumbled upon approximately 10 years ago has been the use of, in children with recurrent low-grade tumors, the use of bevacizumab and irinotecan. And this really was just out of desperation. We had a group of children that had relapsed multiple times with low-grade tumors, had failed carbovincristine or had allergies to it, had failed other drug regimens like TPCV. Some had failed radiation, and we just didn't know what to do with this group of patients. And as luck would have it, the first child we treated on this regimen was a 6-year-old who had this huge low-grade tumor, had already failed 3 chemotherapies, had failed radiation, and was functionally blind for the last 6 months, had only light perception vision, and actually at 6 years of age weighed about 30 pounds. This was a really sick kid, and we had nothing else to offer. And we tried, out of desperation, because we were using the bevacizumab with the irinotecan in high-grade tumors, we gave it a try. And this is what happened in this one case. And then if you don't believe that's the enhanced picture, this was the flare picture before and after. And that is the most dramatic response we've seen with a recurrent low-grade tumor. So that led us to try a small series of our own at Children's in Washington, D.C., that Dr. Wong helped us out with Dr. Avery, and we saw that was the best response we probably saw, but we did see excellent responses in about 7 of these 10 multiply recurrent patients. And probably as importantly, the thing that shocked us was that, usually you have fixed neurologic deficits, and we saw improved clinical benefit, including that child I showed you on the first one, went from essentially light perception to be able to go back to school. has a field deficit, was able to go back to school and use a blackboard. And that's the thing that impressed us with this regimen. We've had improved hemiparesis. And then for children with the diencephalic syndrome, we had about 4 of 6 that actually started eating again without supplementations. So this went to a more national trial, and this only looked at low-grade gliomas done by the Pediatric Brain Tumor Consortium, and this has been published. And this is a really good salvage regimen. How you use it, how long you use it, is more of a feel. I don't like using it at full dose every 2 weeks, more than about 6 months, then liking going to every 3 weeks for a few months, and then maybe every 3 weeks, and then a lower dose, half dose every 3 weeks for a longer period of time. But I think if you use this, it's a well-tolerated regimen. There is very little data that the irinotecan adds things to it. We usually are not starting the couple drugs together. We're more using the bevacizumab in that case alone. And this is one of the other things that has been very gratifying. This is one child who was treated on this regimen. You see with this dense field cut. After treatment for approximately a year, this is what the field was. And interestingly, with the tumor starting to grow just a little bit back, maintaining the field cut benefit years after. It's not been everybody. The difficulty, of course, is how long does this last? Does it only last for as long as you treat the child? Some have had longer benefits. Others, after you taper them off, the tumor does come back. The study that Dr. Buffet started at Hospital for Sick Children in Toronto, that Dr. Wong here is our co-PI and is a U.S. lead, is looking at the comparison of vinblastine to vinblastine and bevacizumab for newly diagnosed patients. And we started the carboplatin vincristine. I still am a little hesitant to use this in very young children, but I think it's a really good randomization in children older than 4 or 5 because the carboplatin and vincristine, especially the vincristine, can be so toxic for those children to maintain. And this is a study that is slowly accruing patients, but is starting to pick up some steam. And we'd like to see that this study, which opened in 2016, gets completed. One of its real challenges, as you will see, is it will start to compete not only with carbovincristine, but will compete at least nationally and maybe internationally with a MEK inhibitor study, which I will show you. So this is the trial for newly diagnosed low-grade gliomas. It goes up to age 18, I believe. Dr. Buffet has run the study at Hospital for Sick Children, but Dr. Wong is our lead at Children's and also one of the 2 other international leads. And Dr. Wong's brighter wife, Dr. Hardy, is leading the quality of life in a study on this. It's sponsored by Roche, but it's the first biologic trial. And although we have multiple outcome measures, some of our major outcome measures in this trial is going to be functional. We understand you have to have functional improvement to have this make sense. Ages between 6 months and 18 years. Tumor tissue, if not NF1. All NF1s are allowed without tumor tissue, and we talked about the regimens. Now, that was the first foray into molecular therapy, but it really wasn't molecular targeted. We knew a little bit about low-grade gliomas, that low-grade gliomas did have VEGF overexpression, but the molecular targeted therapy stuff really opened about 15, 20 years ago with the use of for children with giant cell astrocytomas, with the use of the mTOR inhibitors that Dr. Franz and his colleagues at Cincinnati demonstrated. And this was the first real molecular targeted therapy for children with giant cell astrocytomas and tuberous sclerosis. And this was the seminal paper that they published showing this nice response to an mTOR inhibitor for giant cell astrocytoma, which is the common tumor of tuberous sclerosis that is difficult sometimes to surgically resect. And then as they let up on the rapamycin, the tumor came back, and then it got smaller. One of the things, if you read this paper, is that of the first 3 patients, 2 were giant cell astrocytomas, but 1 was actually a pilocytic astrocytoma. Now, So this study aimed downstream at mTOR in this pathway. RAD-001 or everolimus has also been used for children without tuberous sclerosis. There's a pediatric low-grade tumor study that still has not been fully published, but is completed, that showed that a lot of stable disease for children with low-grade gliomas with relatively good tolerability. And then, interestingly, in this study, which still hasn't been published, 4 children had a partial response, a greater than 50% reduction. The majority had stable disease, 6 progressive disease. So it is not a regimen to throw away and to forget about for low-grade gliomas. It's not as active as the MEK inhibitors that I'll show you, but it does have a role, I think. And this is one of the better responses they had on this study, courtesy of Dr. Kieran in Boston, which is a pretty good one. We tried a study about 10 years ago, coupling the mTOR with an EGF inhibitor based on some internal work that Toby McDonald did with us when he was at Children's National, now he's in Atlanta, and showing EGF progression, EGF expression. And we saw some responses. This is a child with a multiply recurrent low-grade glioma, does not have NF, that went on to have this kind of a response for a year. And there are occasional responses, but we did not see any major additional benefit from adding an EGFR drug. This is where we were until about 2007, until about 10 years ago, when this seminal work, 2008, came out from Stefan Pfister's lab in Heidelberg, and there were subsequent publications from other laboratories around the country, especially Boston Children, with Keith Ligon, showing that BRAF gene duplication was a major mechanism or driver for pediatric low-grade gliomas, and this has really changed the way we view these tumors. And this is a summation of a lot of work that's been done by his laboratory over time, but you take a look at pediatric low-grade gliomas, the major driver is a mutation in BRAF, either a fusion, as Dr. Pfister in his laboratory showed, especially in the pilocytic astrocytomas, or a point mutation in possibly some of the pilocytics and some of the more diffuse, and then a variety of other mutations that make up a significant amount. And remember, this does not include the NF children because they don't get biopsied. This is a non-NF, and you see that FGFR is a driver in some. It's an interesting drug. Can you treat it the same way that you're treating some of the more downstream mutations? Do we have to go to a specific inhibitor? And there's a variety of other things. And one of the other ones we're looking at very carefully because there are effective drugs is NTRK as a major driver. But they all signal, and that's the beauty of it, they all signal through this RAS MAP kinase pathway, including NF1, and that's our target. Now, whether we're going to have to go up a higher stream for the FGFR, I don't know over time. But the signaling of all of these through the pathway, with the possible exception of NTRK, really gives us an open window of new therapeutics. And statistically, if you take a look at it, and the numbers have varied tremendously from center to center, that in the cerebellum, the vast majorities are BRAF fusions. And this is important for the diencephalics. Even though we think of it mainly being a fusion, in the non-NF ones, there's a lot of variability, whether it's going to be a point mutation or a fusion, and that's where you pick up some of your FGFR, and there's where you sometimes pick up high-grade tumors because they're midline. In the brainstem, once again, for those that have a BRAF mutation, it's a 50-50 shot, whether it's going to be a point mutation or a fusion. And the spinal cord, similarly, you can't be sure. And then we have all of these other variants that we've never really known how to treat. We use carboplatin and vincristine and things like that. These diffuse astrocytomas, the gangliogliomas, the PXAs, pleomorphic xanthoastrocytoma, that have a fairly high level, maybe even a higher level for the gangliogliomas of specific mutations, especially V600E, which is another major window to move forward with. So this is a schema that we published with the group at a consensus conference about a year ago now. very specifically saying that you cannot really manage low-grade gliomas outside the NF window if you want to use molecular management without knowing what it is. If the tumor's in the cerebellum and brainstem, any low-grade histology, we believe that if BRAF fusion or V600E needs to be ruled in or ruled out. We'll talk a little bit about this concomitant CDKN2A abnormality, which is becoming an increasing... Can we kill that? I think someone's giving their own lecture. Could we turn that off? Thank you. Okay, so this is an interesting issue, that in some of our recurrent diseases in our patients who do not respond to frontline therapy, they have concomitant secondary mutations, and these can also be targeted. For the supranatorial non-midline, it's also a little bit of a different thing, because you're more likely to have a V600E or an FGFR, especially for the DNETs, and they have a different pattern. The reason this is important is one of the mistakes that has often been made with the low-grade gliomas is to waste tissue, to take the low-grade gliomas and suddenly test them for IDH1 abnormalities, which is very infrequent in pediatrics. It's something you can do down the line, but if you want to use your tissue appropriately, this is a good framework of how you should molecularly interrogate these patients. And then the bottom line on all of this is that the benefit to the patients for all of these was that there were drugs being utilized for melanoma, for other conditions, targeting MEK. So with a cooperation of industry, to be very honest, they allowed multiple investigators, including ourselves, to come in early with the MEK inhibitors to see if, for those patients, especially fusion abnormalities, if we can go down this pathway and make a difference. So taking a look at it, one of the other questions that comes up is this a single pathway disease, or are there escape pathways? And I think at this point, much of the data suggests for the BRAF fusions and for the point mutations that we are dealing for the first time in pediatric neurooncology with a general single pathway disease. And that's what we've always been looking for, a single pathway that we could treat and modify disease course. How many of these patients will then activate PI3 kinase? That still is to be determined. How many have other escape mechanisms? And also it's the same pathway for NF. And that's very important. So this is some of the early results with the MEK inhibitors. This is a child with a multiply recurrent low-grade tumor with a dense left hemiparesis. This is after about 4 months of treatment with MEK. And one of the things you have to be very cognizant of is MEK inhibition sometimes gives you an immediate signal, but you can't give up on the drug for 4 to 6 months as long as you're getting stable disease. You don't progress, but you may take a while to shrink. And this child was as gratifying as this getting smaller from here to here on the FLAIR image was that the child clinically improved. So the first study that was done with a MEK inhibitor was using the AstraZeneca drug sulimetinib by the PBTC-029 phase 1 study. This has been published. There was a learning curve on this study. Then many patients early in the study, a lot of them went off study because of what we thought were toxicities that could not be reversed. But these were rashes, they were GI, and to some degree they were CPK, a muscle enzyme elevation, which we learned the hard way that we can get patients through these trials. And the impressive result is that in this phase 1 study trying to get the MEK, there were 9 partial responses occurring all over the case, and some of them late. And we also looked at BRAF, but BRAF was not the driver of this study. This was all low-grade gliomas. So this was the phase 1 study showing a lot of different tumors. This is the BRAF fusions were in blue. This is a waterfall chart. Some patients grew on the study, but even on this phase 1, some benefit although less than 50% for about half, was seen in about 70% of patients. And many of these so-called unknowns were actually neurofibromatosis. We just didn't have tissue. And some of the results are very gratifying. This is a child with a widely disseminated, has neurofibromatosis, a very unusual case. And after 4 months of treatment, went down to this on the enhanced scan and maintained the response for quite a period of time. Overall, the study has now gone into the phase 2 of the study has been completed. And for the MEK inhibitors, and this is Dr. Fangarusa's data for the PBTC that we're part of, if you take all children with BRAF, either mutations or fusions or points, you see a response rate of about 70% of some degree of shrinkage, with about half of those or more having a greater than 50% restriction. These were non-NF patients. And this is what you saw in NF patients. Almost every child with a recurrent low-grade glioma who had NF, at least temporarily, had shrinkage of the tumor. That was very impressive to us. The real question that comes up in the data that's still being fully analyzed, and this is still preliminary, and I thank Jason for allowing me to share it with you, that if we take a look at 25 patients with NF1, and we treat them, how long does response last? 16 of 25 completed 2 years of therapy. And of the children who actually completed therapy, and they were allowed to go off early, some kids went off in 1 year, at the time of this analysis, of the 25, only 6 had to go back on treatment. And even in those that did go back on treatment, it took them a few months to a few years to go back on treatment. And 18 of the NFs remained stable. And these are recurrent low-grade tumors. For those with the BRAF fusion or mutation of the chiasm, here we see a little bit more of a mixed pattern. Although we had a high response rate, 14 of 25 completed all. However, 7 did develop progressive disease at some point. And of the 18 that are off treatment, and these numbers are rising because we just have to get 3 of them, I think 10 have been retreated. And now 8 remain stable. So the durability of response is not perfect on this, but it really is a good approach for recurrent disease. So what is the next step with these? Well, there are going to be 2 next steps and maybe 3. For the patients with NF1, there's going to be a prospective study that should open in the United States and probably in Europe and certainly in Canada, that is going to open within the next 3 to 6 months with a 2-to-1 randomization of the MEK inhibitor, the sulimetinib, compared to carboplatin vincristine. The primary outcome measure will be progression-free survival, but the co-primary will be visual acuity for the chiasmatic tumors. The difficulty with this study, to do this, it's still at most a 7-year and as low as a 5-year study. So it's a very long study to get the answer. And this will be the randomization. This has been approved by the drug company, by the U.S. Regulatory efforts, and the protocol is rapidly being developed and should be open, we hope, in October for newly diagnosed disease. Now, I just have one caution. The study is going to be used to try to prove that the sulimetinib is equal to the carboplatin vincristine in this arm. I showed you already that there's about a 70% initial response rate, and and many of those children hold their responses. So it's going to be a very high bar for the sulimetinib, which is the AstraZeneca drug, to work. This is one patient, just to give you the reason it's going to be a high bar, that had a diffuse NF1 with a diffuse low-grade glioma and had this kind of a lovely response. This is a child who was treated with carboplatin vincristine. So it's going to be very difficult for the MEK inhibitor to be better, and it's going to be a very interesting trial to move forward with. And this is the flare image of this child 9 months of the carboplatin vincristine. We also think there's going to be a learning curve, and the concern that I have is that some patients will drop out of study too early with the MEK inhibitor because of rash. This is a study that was wanted to be done by the Logic group in Europe. They wanted to do a 3-arm study. That study has yet to open. And one of the issues with all of these drugs is which is the best drug. AstraZeneca has sulometinib, Novartis has trametinib. Pfizer had a drug that is really not going to go forward. There's a company, Array, that has bimemetinib, and Genentech has cobimetinib. And they have various different qualities. Some, like the sulometinib, has not been available in liquid form, although a sprinkle form is coming up. Novartis has been liquid, and Novartis has been more willing to do combination therapies. But it's very difficult for us as a medical field to understand which drug is the best drug. What's the best toxicity profile? What has the best CNS penetrance? The preliminary data with AstraZeneca drug suggests that it would have terrible CNS penetrance, yet it has great responses. And is it going to be better than the BRAF point mutations, which we'll talk about in a second? The Novartis trial with trametinib has completed a phase 1. The phase 2 is partially completed. They did not do a lot of focusing on NF, and that study is underway. And the trametinib has an expansion looking at a small group of patients with BRAF point mutations, but they have not been a major factor until the expanded trial on the low-grade gliomas, although it may or may not be as good a drug. It is different, very different chemically. Now, initially, there was going to be a trial of comparing carboplatin to trametinib for children with progressive radiation or chemotherapy, naive low-grade gliomas. That trial has now been moved to sulometinib. So once again, that's going to be the workhorse trial in the United States. A third drug that we're very interested in is an array drug called MEK162, or bimemetinib. Dr. Robinson is the lead of this trial. And one of the reasons we were very excited about this trial, that chemically, this MEK inhibitor is almost exactly the same as sulometinib. In fact, it was devised by the same company who sold it to different companies. This had a liquid preparation and was allowed for children less than 1 year of age, and it is just entering phase 2. And this is going to be a complex phase 2, looking at different strata, including children with low-grade gliomas, children with NF and low-grade gliomas, and even an area where you could do a target validation, where prior to initiating of treatment, you can give the drug and then do a biopsy afterwards. The Pfizer drug, I don't want to spend any time on. I don't think that's going to move ahead. And the major issues with the MEK inhibitor is which drug is going to be the most effective. They are different molecular structures. Which is going to give us the best functional outcome? And will toxicity vary, especially as we get into the very young drugs, the young kids? And which drugs will actually survive to be able to be given in these studies? And the effect of MEKs on functional outcome is going to have to be the real answer. Another question is going to be, are we going to use combination therapies with the MEK? And what are we going to combine it with? If MEK is as good as we think it is, but wears off after a year or 18 months, can we add chemotherapy or another molecular targeted therapy to move on to something else? This is something we've been trying to push the drug companies for, and ultimately, especially with the Novartis and trametinib, those kind of studies are going to go forward. Mainly asking the question, are there different pathways that we also have to hit with these same patients? So the combinations, there's use with chemotherapy was initially approved in 2004, disapproved by the drug company because they were worried about added toxicity and its ability to get it to market. And we tried to do it with both vinblastine and carboplatin. Now there is going to be a trial with it coupled with an mTOR inhibitor in one subgroup of patients. There's going to be a trial out of Denver coupling it with hydrochloroquine, looking at autophagy, planned with trametinib, and we said the mTOR inhibitor trial is moving forward. One of the other trials that I think will move forward for the recurrent low-grade tumors, even with NF or without NF, that are biopsied and are shown to have a CDK of 4/6 mutation, CDK and 1/2 mutation, is what we with the CDK4/6 inhibitor that we're asking to try to do with Novartis. The other side of the coin is the BRAF V600E as a target. That has been shown nicely, again, in 40 to 50. 40% of the chiasmatics may have that. And there's been nice work, Mark Kieran, only insofar in an abstract form, shown in 15 pediatric low-grade gliomas with mutant. This has a paradoxic effect in the fusion. It actually, because of uncoupling one side but not both sides of the fusion abnormality, causes actually paradoxic growth. Had a very good response to VRAF 600 patients with 8 partial responses and 6 stable diseases, and that is held up. And some of these responses, as in this one, has been a really good one. So other trials with a different drug, that was dabrafenib with vemurafenib, have also gone forward, showing a good response rate. Trametinib in combination with dabrafenib is being utilized in children with recurrent refractory tumors harboring V600E mutations with a dose escalation, and this study is moving forward. And we believe that looking at what are results of the multiple consensus conferences, we really think that the MEK inhibitors need to be pushed forward, as do the BRAF point mutations. And these are conferences that I led with Dr. Buffet and Dr. Kieran and Dr. Pfister. The first conference really set the scene of where we need to be, and the results have been published. The second conference was really more important. That's where we went on and we said we needed an integrated, molecularly based classification system, that the need for therapy is to be molecularly characterized, and that has been published. And this led to this kind of schema that we talk about and we think is going to be critical for these patients. And in the third conference that just met, we invited industry, and this is where we got agreement to move ahead with the newly diagnosed patients. So the field is moving very quickly. And remember, this is a field, although I feel frustrated that we're just getting into newly diagnosed patients, it wasn't until 2008 that we even knew about BRAF. So this has been a very quick march along of changing what we hope the standard of care for these patients. I'm going to show you just one other tantalizing work. This comes from Yuan Zhu in our lab, who's been studying the development of NF1 gliomas in mice, showing that they develop very early in life. He was able to show this kind of growth, and by 15 days of life in a mouse, the glioma in his model is well established and continues to grow. Why it becomes very exciting is that he looked at the MEK data and said, okay, you guys give it late, when the kid is 5 or 6 or 3 and 4. What happens if you were able to identify these tumors early enough in life to give it in mother's milk, to give it when the mouse was suckling? What would you do in an NF population? And he used the Pfizer MEK inhibitor in these suckling mice. And this is the amazing thing that he saw, that these tumors never ever formed. If he could give this in a small window of opportunity to these mice before they developed the tumor never grew. So if we can figure out as a group who with neurofibromatosis is to get a low-grade glioma, we could theoretically prevent, if we had the guts to use the drug this early, we could prevent the development of the tumor. That's the ultimate goal of what neurooncology should be, not to treat the tumor, to prevent it. Our difficulty is, can you identify those patients early enough in life that are going to develop the glioma to try to get this in a very early window. So where are connotations as we end up in the molecular era of low-grade gliomas? I think that the molecular treatment with the MEK inhibitors or the V600E inhibitors have not yet replaced conventional chemotherapy or for some degree radiation. But it may indeed change the way you're going to sequence these drugs and maybe will even further be able to push off anything that is harmful. We really know little of the resistant mechanisms. We already know that if you go in with the wrong drug like sorafenib, which inhibited V600E, you got paradoxic growth under mutations. You've got to be smart. And we don't know yet exactly what the need for combination therapy is going to be. We must judge functional outcomes because that may be the only way that we show the true benefit of these drugs. And the long-term outcomes are going to be critical. And one of the things we are doing, again, with our neurocognitive group at Children's is any child that goes on a MEK inhibitor, we do neurocognitive testing before or after, and after they're on it. Interestingly, there's a little bit of data, just like with the rapamycin data with the tumor sclerosis, that we might even be seeing improved outcome in the NF patients cognitively. And there's always been this question for low-grade gliomas, if they had seizures or cognitive problems, would MEK inhibition hurt or help those? Just like in TS, RAD-L1 or rapamycin analogs do seem to help cognition and control seizures. These are the things that we're trying to work out. But despite this, there's a general consensus that trials for newly diagnosis need to be developed. The trials should be shorter. They have to be still compared to a standard. They must be biologically informed. And I think that it's very hard in this era not to do BRAF testing on your low grades. They have to have functional outcomes, and we have to monitor neurocognitive and late effects. But that overall, the future for low-grade gliomas, for the translational, as frustrated as we were for medulloblastoma and maybe for DIPGs and other high-grade gliomas, that we haven't been able to translate. For the low-grade gliomas, we're already into translation. And the question is, how fast do we do it, the right drug with combinations? But this is really when neuro-oncology has made a dramatic move. Thank you very much for your attention.